Hey guys, welcome to another episode of Health Matters, the Health 365 podcast brought to you by yours truly, Danielle Linane. Today, I sit down with Dr. Zenobia JonesFoster. She is the Medical Director of Hospital Medicine for Wellstar Kennestone Hospital. Dr. JonesFoster wears so many hats and has an impressive background. In this podcast specifically, she helps shed some light on hospital medicine, what it means to be a hospitalist, which is just so interesting. So guys, you don't want to miss this. Grab your paper and pens and listen in. Hey guys, welcome to Health Matters. So today I'm really excited for this next series we have coming up in general, but today we have our Medical Director of Hospital Medicine, Dr. JonesFoster, with us today. Welcome, Dr. Foster.
Thank you.
JonesFoster, excuse me.
Thank you for having me.
Oh, thank you for coming on with us. So I always like to start off, give the listeners a little introduction into yourself, kind of your background, a little bit of your education, and what brought you to Wellstar.
Okay, great. Well, we will start from the beginning. So I'm originally from West Virginia. I came to Atlanta to attend Emory University.
Okay.
Got my undergrad degree in neuroscience, and then actually I didn't go straight to medicine. I went into the business side of healthcare.
Really?
So after I got my undergrad degree, I stayed at Emory and got my master's in healthcare policy and management at the Rollins School of Public Health there. So after I finished that, I worked in healthcare consulting. So I joined on with PricewaterhouseCoopers for a couple years, and I did healthcare consulting. I got to travel the country and see different healthcare systems and different models and help them with, performance improvement initiatives and patient satisfaction, those types of issues. After a couple years of doing that, I felt, something was missing. I was really drawn to the clinical side as opposed to the business side. So I decided I want to go to medical school. So I went back to West Virginia and graduated from Marshall University in West Virginia with my medical degree, and then came back to Atlanta and did my residency at Emory. After I finished up with Emory, there was a pull to stay at Emory because I really love the teaching environment, working with the residents. But I thought, you know what, let me give this Wellstar a try. I heard great things about it, and I said, let me get my own sea legs and see what it's like outside of the academic environment. Because at that point, there was no graduate medical education program at Kennestone.
Right.
So then I joined Wellstar as a hospitalist, and that's kind of what brought me here.
Yeah.
And then over the years, I've been practicing as a hospitalist, and then have been able to couple my business background with my master's, with my clinical background. So now I get to do both. I get to do the administrative side, and I get to do the clinical side, and I get to be involved in teaching. So I really love what I do.
Let's say you're just a jack of all trades here. It sounds like.
So part of my time is spent as medical director for hospital medicine here at Kennestone.
Okay.
The other time is spent as the associate program director for the internal medicine residency program.
Okay.
And then clinically, I still round on patients and I work with the residents to take care of patients here at Kennestone.
So basically, you're Wonder Woman.
No, no, not that. But I am happy. I love what I do. I really we get to see people at a very vulnerable time in their life and really help them through it. And it's a blessing to be able to do that.
So now, how long have you been with Wellstar? When did you come to Wellstar?
So I've been here about 8 years now.
Okay. Mm-hmm. And then you mentioned the graduate medical program. How long has that been in effect here?
So it has been going, this is the fourth year.
Yeah,
we just graduated our first class of internal medicine residents July 1st.
So cool.
And so all of them, graduated and got great jobs in the community. And the majority of them actually stayed within Wellstar Health System, and the majority stayed in Georgia, because the point of us starting this program was really to help retain a lot of the wonderful medical students that the state of Georgia produces. There just weren't enough residency positions for those residents to stay.
Right.
And studies show that residents actually end up staying where they practice their residency training.
Which makes sense.
Yeah, it makes sense. And so we were losing a lot of our Georgia talent, and then we have counties in Georgia that just don't even have primary care doctors.
Right.
So we were really excited to bring it to Kennestone, where we have such pathology, we have such volume, we have phenomenal physicians to be able to provide a great education for them. So
that's so cool.
It's great for the community.
Yeah, absolutely. I've been with Wellstar for about 10 years now. and I always ask why aren't we a teaching hospital? Well, you know, we, like you said, we have the volume, we have everything we need to be that in such wonderful departments and everything. So it was really when I heard that it was coming, I was like, there we go, here we go, like, this is it.
That's great.
So I want to talk specifically, I know you wear a couple of different hats, but I'd really like to focus today on your role as the medical director of hospital medicine.
Okay.
And let's talk about being a hospitalist.
Okay, yeah.
So, you know, some people have a hard time understanding,
Yes.
I think, because, I mean, you think you've got hospitalist and internal medicine and a primary care physician. You know, there's all of these different things in the realm of internal medicine. So how do you explain this to people?
That's a great question.
how do you also, so kind of a two-part, how do you explain this to people, and then how do you work with the surgeons or with their primary physicians, and how does all that tie in?
Yes. So the reason why people are a little confused is because hospital medicine is kind of a new field. So
Okay.
It's about 20 to 25 years old.
In medicine, that's a
in
baby,
general,
that's
right.
a toddler.
And so most hospitalists are internal medicine physicians. You can be a family medicine trained physician too, but at Wellstar, most of our physicians are internal medicine trained.
Okay.
And those physicians had made the decision that they prefer to work in an inpatient hospital setting. They prefer severity of illness that's more acute instead of working in a clinic where you have established relationships, you deal with preventative medicine, you deal with chronic medical issues. And so basically those physicians have trained in internal medicine.
Yeah.
They graduate and they decide they want to do hospital medicine.
Can you give us an example of like what is something acute, just for our
Sure.
listeners? What
Yeah.
would that kind of look
So
like?
patients that come into the emergency room and they may have a stroke or they may
Right.
have pneumonia
Right.
or they have chest pain and they are too sick to go home, so they can't go home.
Right.
They may not go to the ICU, but they need to be admitted to the hospital and they need to stay here for a couple of days to have their diagnostic workup done.
Okay.
You know?
Yeah.
And in the old days, before 20 years ago, basically primary care doctors used to have to see their patients all day long, and then in between, as in on their lunch break, after hours, early in the
Really?
morning, they would come to the hospital and round on the patients that they know. So the model is good in that when you're sick, you really want to see someone you know and you trust, and that's your primary
Yeah.
care doctor. But it was overextending primary care physicians in that they couldn't be two places at one time. They already have so many demands in the clinic that the model wasn't sustainable.
Yeah.
And so thus came the development of hospital medicine. So
Was physician burnout high at that point?
physician burnout because it was an issue and obviously
Yeah.
is still an issue. But
yeah.
hospital medicine came into existence and we're really able to provide 24/7 care. So we have hospitals here all the time. We are more versed in some of the acute issues that patients may have in the hospital setting. We also work a longer stretch. So we're able to provide continuity. We work 7 days in a row.
Wow.
We're able to provide continuity for those patients when they're actually in the hospital. And then we're able to help coordinate the care on the inpatient setting so that once all their care is wrapped up, they can be discharged and we can facilitate a transition of care to their primary care physician.
So is that where, you know, we hear sometimes that the hospitalist is like the captain of the ship, so to
right.
speak. Is that kind of where that comes in, or why do you think
Correct.
you guys have been kind of doffed that,
Yeah.
so to speak?
Well, you know, it's interesting. Most people that work in the hospital have actually never really been patients. Some people have been patients, but if you've
Myself,
ever,
I've never been a patient
right? And
in
if
a
you've
hospital.
ever been a patient, it's a very foreign and uncomfortable experience. Not to mention that you're here because you're ill with
Yeah.
some sort of issue. People are coming in your room at all hours. You don't know who they are. It's just a very confusing environment.
Right.
Not to mention there's multiple different physicians you're seeing that you may not know. And so one of the biggest complaints for patients is that they really don't know the plan. What is going on?
Right.
And so the hospitalists, because we work longer stretches, we work 7 days in a row, we're able to provide continuity during that time period, and we're able to coordinate with the different subspecialists. So we're able to kind of put the whole picture together. So one patient may be here and they may have a cardiologist involved, a nephrologist involved, and a pulmonologist involved in the case. And they may rotate every 2 days because they're doing clinic, they're
Yeah.
doing procedures, so they may not be able to be there 7 days in a row. So we're kind of the the glue that kind of puts all the pieces together. And so we work heavily with the subspecialists. We also are very integrated with like care coordination, our physical therapy team, our pharmacy team, just to bring all parts of medicine together so patients get, well-rounded care, and they're really aware of what's going on with their plan of care. The other thing is we're really involved in making sure that patients don't stay here longer than they need to be, that their care is expedited, that we're focusing on things like patient satisfaction, like mortality, decreasing risk of infection, those types of things. So.
Right. So that you kind of went right into my next point there. I like that. So how do you ensure that a patient understands things like a diagnosis, side effects of medications and other things? So the reason I say that is because I had an instance, my grandfather was in the hospital and, we worked during the day, we would come in the afternoon, and we'd get in and it's like, who came in today? A lot of people. Yeah. A lot of people did. Well, what'd they say? It was always like a question or, they said this, this one said this. And so kind of what is your method to make sure that patient really understands and has a knowledge of what they're going through, what's happening, what treatment process and things like that? How do you
So there's a couple of ways we do it, but mainly it's teamwork. Yeah. So within hospital medicine, we have developed these acute collaborative care units. And they're geographic units in the hospital where one physician mainly takes care of the patients on that unit. Okay. And they work very closely with all nursing staff, with the pharmacy team, the care coordination team, and we tell our patients and our families that, hey, between 11 a.m. and 12, we are going to be doing coordinated rounds. So that's the time where we're going to be available for families to be aware of what's going on. Right. We recognize that patients' families cannot be here 24/7. No. People are coming in and out, and it's difficult. They have jobs. They're not able to be here. And so we do our best to call those family members to keep them updated, but we let them know that we do group rounds on these acute collaborative care units. And during that time period, we come in as a whole team. So it's the physician, it may be the residents, it's the charge nurse, the nurse taking care of the patient, it's the pharmacist, as well as care coordination. And everybody discusses what's the plan. This is your discharge plan. The care coordinator goes over. Right. This is what's going on with your medication. The pharmacist goes over. And then the hospitalist brings the medical plan together and says, this is what cardiology, nephrology are saying. This is what I'm saying. This is your tentative discharge date. Right. Do you understand the plan of care? Do you have any questions? And so patients can see this actually is a coordinated team effort. It's not one person popping in, another person popping in. We really do work together, and patients really love that aspect of it. To answer your question about, how do patients really get to understand their diagnosis, side effects of medication, again, we rely on our team members. So, for example, say a patient is taking Coumadin, right? Yes. If they get started on Coumadin for a new medical condition, there's a lot of things that go into Coumadin management. So me as a physician, I would go in and explain the medication, talk to them about the side effects, the risks, the benefits, and if the decision was made to move forward with starting that medication, then I would contact the pharmacist and say, okay, this family has decided they want to move forward with Coumadin. Can you go there and provide the education? So the pharmacist will go in and they'll provide Coumadin education, talk to them about what foods they can or can't eat, and really the pharmacokinetics of Coumadin and that sort of thing. Exactly, yeah. Then after that, I'll call my care transition coach, who are, they work within the Department of Hospital Medicine, and they help facilitate transitions from the hospital to the primary care environment. So if you're in Coumadin, you definitely need to have your blood levels checked pretty soon after discharge. So they will meet with you, talk to you about your schedule, understand when that follow-up needs to happen, and then they'll help arrange that follow-up. So really, it's very much a teamwork effort, and we're kind of the quarterback or the captain of the ship that's just kind of facilitating all that stuff so that patients feel like, okay, I feel that this is a lot of coordination for me, and I understand all the different players that are involved in it.
So this is interesting. You kind of notice this pattern of comprehensive care really coming in and everything, and that's what kind of how I see what you're doing there. You've got your pharmacist, your care coordinator, you cardiology. I spent some time in bariatrics a few years back, and we had the surgeon, the registered dietitian, the psychologist, and the exercise physiologist. So to me, I'm really just talking and making a connection in my head. I just had an aha moment that this seems to be where everything is kind of moving to in medicine. Would you agree with that?
I would agree, and that's the direction it needs to move. Just because the body is so complex. It's just not one-dimensional, right?
No, it's not. I always use the example of like the body being kind of like a car. You know, you got a transmission guy, you know, you got a tire and brake guy. You've got a different guy that will paint your car. So you think the same way for doctors and for bodies, right?
And you know, when you go to the shop and you don't know a lot about cars and they come out and they tell you, you need this, this, and that, and you're like, okay, thanks.
That's exactly right.
And that's how patients feel, you know, and it's hard because the other thing is that they're at their most vulnerable moment. So they're not going to be thinking about the questions they need to ask and those sorts of things. So
it's really awesome. I love learning. And so we talk about making a connection with the patient. You know, you kind of you're siloing me into all my points, and I love this. But that connection point, and how do you do that? What do you do to try to, because no one person's going to get along with everybody, right? And that's not what it's about. But how do you make a connection with your patients to make sure that care experience, you know, that customer experience is good for them?
Yeah, it's a great question. So we're really at a disadvantage because most surgeons, primary care doctors, they know their patients, right? They know their families, they're comfortable with them. We walk into a room, you're sick, you're vulnerable, and now you're going to put your life in my hands, and you just met me 2 minutes ago, right? Yeah. So it's hard to automatically establish that rapport where you're comfortable. Yeah. So it's a little bit of an art that you have to learn. Yeah. So hospital medicine falls under Wellstar Medical Group. Okay. And we have a hospital medicine departments at 9 of all the 11 hospitals here. Wow. So we're a very large group. In total, WMG sees about 1,100 patients daily in the hospital. And we're coordinated. So I work closely with the medical director at Cobb, at Paulding, at Douglas to make sure that we're providing coordinated care that's consistent. We learn from each other's mistakes. We learn how to make things better together. And so one of the things we try to focus on is patient satisfaction and patient experience to make sure that we are doing everything we can to make sure that patients can have a good experience despite it being such a horrible time in their life. And so we partner with physician coaches. They help around with us and they give us feedback.
The physician coaches, that's a relatively new area, am I right?
I would say that's correct. Okay. Yeah, I would definitely say it's correct.
Can you talk about that a little bit?
Yeah, so we have a physician coach that kind of works with us. They will round with us, observe our encounters, and then provide us subjective feedback. Say, you know, you did a great job, you know, expressing empathy. One thing you could do was you could sit in the care chair. We have these chairs and rooms where you sit down and talk to patients. Patients feel that they, you know, get more time if you're sitting down as opposed to you're running in and you're running out of the room.
Standing over them,
It's just not comfortable looking up at somebody. You're in a gown, and, you know, it's just not a comfortable environment. So they teach us techniques to show empathy, to make sure we're listening to patients. Yes. Some of our physicians, myself included, can talk fast. And you need to slow down to explain complicated things to people. And so we can all improve every day. And so we are pretty proactive in trying to give feedback to our physicians so that they are, you know, continuously trying to improve themselves. But it's difficult, especially when you don't know their patients or their families. And so we really work hard to try and connect with them, explaining things about their medical conditions, keeping them up to date with tests when tests get ordered, following up with them to talk to them about what the results are and what the implications are. And as we do that and answer their questions and make sure they know that we're available to them, right, there's more comfort, and we're able to establish that relationship and hopefully get them through their acute illness.
I just think a lot of the times it's not even just in the medical field, but communication is key.
Correct.
For any relationship.
Yes.
And do you notice maybe if you get patients who don't have that great experience, do you see communication as being one of, I haven't heard from someone in so-and-so, or I haven't,
I think that's a component of it.
Okay.
But I always have to remind myself that, people aren't their normal selves when they're in this type of
no.
environment. And a lot
Anxiety's
of times,
high, and absolutely.
Anxiety's high. There's a lot of families and members involved.
Yep.
And so trying to bring all the families together and, and provide empathy and understanding that this is very difficult for them. So
Absolutely.
So we work hard to develop those relationships in the short periods of time that we see and get to know those families.
Which, you're right, it's definitely an art, because to relate to someone, what if they're only here for 24 hours?
Correct. Yeah.
That's hard to do.
It's very hard.
Hats off to you.
Oh, thank you.
Hats off to you on that aspect of things. So this question, you've kind of touched on it a little bit, but elaborate a little more on how the Hospitalist has changed that healthcare delivery model. We already talked a little bit about it, but just kind of give me a little elaboration on that.
So a lot of leaders within hospital medicine sit on multiple committees within the hospital. So mortality, myself, for example, sits on way too many committees, but like mortality committees where we review mortality cases and discuss things that we have learned where we could have done better. What did we learn from those, and how can we apply them to the next patient to just get better and provide world-class healthcare? So we sit on mortality committees where we review that stuff and then implement change and then make that change.
Awesome.
The other thing is length of stay, trying to make sure that patients aren't here longer than they need to be, because the longer you're in the hospital, the more likely risk of infections, weakness from not walking and getting up out of the bed. So our goal is to make sure patients are here as long as they need to be, but not longer than they need to be. Correct.
I could imagine fall risk reduction
would
be a good thing too, post hospital too.
Right. And one of the interventions we've really been working on is on mobility.
Yes.
We don't want people to get out of bed and fall, obviously, but we want them walking. We want them moving because we don't want them to get deconditioned.
Yeah, absolutely.
Exactly. So our hands are in a lot of areas within the hospital, and we work very closely with the hospital leadership team to make sure that we're addressing the needs of the system, and they're working closely with us to hear what are our patients saying and what are the needs that we have to make sure we're providing quality care.
That's awesome. That's really, now outside of the hospital setting, you pass things on to primary care physicians and outpatient pharmacy, I'm assuming, maybe even some physical therapy. So it's not just the hospital setting either, right?
Correct. So when we discharge patients, we transition them to their primary care. Now,
what is that transition? Sorry, what does that transition look like?
So traditionally, we have care transition coaches within hospital medicine, and so they'll provide discharge summaries to primary care providers, or notify them that their patient's in the hospital. So they get a notification through Epic. The beauty of Epic is that we can all stay connected, and
electronic
we can see
medical record.
Yeah, exactly. So we can see what's going on in the inpatient side, we can see what's going on in the outpatient side, and provide that communication. We see a lot of patients that don't have any primary care provider in the hospital. They're going to urgent cares, they're going to ERs, but they haven't had one preventative visit, no regular, visits with a primary care physician. So making sure that when we're discharging those patients, that they are appropriately set up with a physician, or if they have Medicaid or they're uninsured, we opened our graduate medical education clinic. So we're able to provide care for patients that didn't have opportunities before through that clinic.
Really?
And the beauty is that they're seeing these residents on the inpatient side, they're seeing the hospitals on the inpatient side, and then they're getting to still see them in the clinic side. So they're providing that continuity from the inpatient environment to the outpatient environment through the graduate medical education program. And we've really been able to provide a lot of care to people who wouldn't have received care and would just be right back into the emergency room.
Now, did that start with the graduate medical education program?
Yes,
so that's been about 4 years now as well?
Yeah, this is the start of the 4th year. So 3 full years.
So cool. That is awesome. I didn't even know that. I didn't know that was something that we had. Now, I want to back up a little bit. It's kind of a hot topic, and from a wellness standpoint is, in your opinion, why do you think people don't have PCPs? For me, I've been in healthcare for 10 years. me and my PCP have a very good relationship, but I work in the industry.
Yeah.
Why do you think people don't have those PCP visits? Because is it correct? Preventative, it should be covered under their insurance, correct?
Well, and that's the key if they have insurance.
Oh,
right?
yes.
So we do have a lot of people that they're not able to afford insurance. They work, they have jobs, they make income, but they have to pay their bills. They have to have a place. They have to support their families.
Yeah.
And if they're relatively healthy in that they don't have symptoms,
Right.
they may not seek a primary care physician.
Right.
But you can have very elevated blood pressure and not have
feel
any
anything.
symptom at
Yep.
all. But meanwhile, that's causing havoc on your kidneys, on your heart, on
Yeah.
your brain, and you just don't know it. You know,
Right.
same with diabetes.
Yes.
And so you triage. You say, what's most important? Well, I gotta, have shelter. Gotta have food.
Gotta eat.
If I'm okay. And the truth is also there's a lot more urgent care centers than there used to be.
Yes.
And so people kind of use that as their primary care, and that's not really what they're intended to be for.
Correct.
So I encourage people to really establish with primary care physicians, because if you do have insurance, those visits traditionally for just maintenance, they're covered,
Yeah.
And even some small visits here and there can really prevent you from having a large hospitalization and preventing an acute illness that
Absolutely.
could happen.
Absolutely. So what is your advice to listeners? So let's say that they're a patient or they have a loved one that is a patient. What are some of the key things that they need to know before getting discharged or before their family member or loved one gets discharged? What's
Gotcha.
some kind of good
Yeah.
things to ask?
So because it can be overwhelming with the number of people that they see, the number of visits that they have in their room when they're there, I really actually recommend for patients and their families to bring a notebook and a pen.
Yes.
And
Old school.
Right? Old school. Okay, maybe a laptop if you're making fun of me.
Notes. I'm not making fun of you. No, the notes on their phone.
The notes on your phone.
I'm
We get
old
that a
school.
lot. Right.
Clearly, you can see me taking notes right here. I'm very old school. So
Because it's important to know who's coming in your room, what are they doing,
Yeah.
asking questions, to be involved in care. And the thing is, you have questions. You have tons of questions.
Write 'em down.
And the doctor comes in with
Yes.
like an entourage of like residents and pharmacists, and all of a sudden your 10 questions become, no, thank you, I'm good. And we get that, and so we really recommend patients and their families, if they have questions, write them down.
Yes.
And then we would love to sit down with you and go over them one by one by one, or answer any questions that you may have about medicines that were given, or diagnostic tests.
yeah, don't be bashful. Write
Don't
them
be
down.
bashful,
Yeah,
exactly.
write them
And-
down.
and-
That's what they're there for.
Exactly. And just like families can't be there 24/7 at the bedside, the physicians can't be there 24/7 at the bedside, but we always want to collaborate and work with families to make sure that they know that we're here for them.
Yes.
And that we want to help them through this process. And so encouraging them to ask to speak to the physician, ask what's the plan of care, ask what the transition of care is, be comfortable with your medications at discharge. We have a multitude of resources to provide education, whether it's diabetes education, new medication, tests that need to be follow up on. We want to make sure that the communication plan is clear. So for families, it's really helpful if we can get that information too, because if they come at 9 p.m.,
Right.
the doctor may not be there. There'll be
Right.
another doctor there, but it wouldn't be the one who's
They
taking
saw
care.
before.
Yeah, exactly. And so that's probably my best advice to
Absolutely.
to
Well,
families.
you're like I said, you're preaching to the choir, because I have a notebook for probably every different aspect of my life that I write in. I got a grocery notebook, a home notebook, a work notebook. I even have a moving notebook. I just
wow.
moved, so I had a moving notebook for that. So I think that's just such great advice. And Dr. JonesFoster, thank you so much for coming today. We talked about a lot of great things that I hear people all over the community just, what is that? What's the difference with this? And
Yeah.
I just want to thank you for coming in and sharing your wisdom with our listeners. This is great information that you've given us
Well,
today.
thank you so much for having me. And if anybody in the community has questions as it relates to the Department of Hospital Medicine, Wellstar Medical Group, we are happy to answer any questions or help in any way
Now,
possible.
where can they find you guys to kind of is there a website or
There
phone
is,
number?
you can find us on the Wellstar website as well, but we also have a hospital medicine office here at Kennestone
okay.
on the lower level of the
Is
hospital.
there one at each
There
hospital?
is one at each hospital.
Okay.
Yeah.
All right. So guys, if you're looking, if you've got any specific questions or you want to talk to someone in the hospital medicine department, could probably call the directory at your hospital,
definitely.
or check the Wellstar website, and you could definitely find. You could even probably find a picture of Dr. JonesFoster up there if you wanted to. Yeah. But again, thank you again, and I look forward to talking to you soon.
Wonderful. Thank you.